Today we have the privilege of having Dr. David G. Moliterno, who's the editor-in-chief of JACC Intervention. Welcome, Dr. David. So tell us about your visit to India and India Live.
Yeah, thanks so much. It's great to be here in India again and part of India Live, a fantastic meeting of experts from not only India but from around the globe. Here at the meeting yesterday, I enjoyed very much the session on acute coronary syndromes and the many different ways to treat them. This is important, a super important topic, not only for India Live, but for global healthcare. We know that in westernized countries in particular, the most common reason adults are admitted to hospital has to do with acute coronary syndromes. And so what I was able to talk about were antiplatelet therapies used following percutaneous coronary interventions. So most commonly, patients are going to receive a coronary stent, then for two reasons. We're going to need to use antiplatelet therapies after the stent is placed. One is to allow the stent to heal in place and not have stent thrombosis occur. And then the second one is to prevent future events from occurring over the upcoming weeks to months. And so really the focus of my talk during this session yesterday at India Live was about how do we choose the drugs, when do we start them, how long do they continue for, and what are the ultimate goals of these drugs. So really a good session and a good meeting.
Great. So these patients need these antiplatelet drugs for long term, and most of the times patients are worried that in the long term they can have bleeding complications. So what is your take on that?
Yeah, so good. That's super important. It's the two balances, right? It's preventing a thrombus or a blood clot from forming, but on the other side, causing bleeding to occur. So I would say over the past 20 years, a lot of the emphasis has been on creating new drugs which are more potent to prevent thrombus formation, to reduce the risk of having a myocardial infarction. But now in the last several years, the idea has been, now that stents are improved, the risk factors are being treated more aggressively, is can we back down on either the dose of drugs or the duration of therapy. Remembering it's two, it's how potent is the medication and then how long do we give it to patients. And so this is what part of my talk was on yesterday. And I think the first aspect is what drugs do we give before the percutaneous coronary revascularization procedure, and by and large it's just aspirin. Whereas in the past, we used to give patients, more therapies up front. We learned that that was not of particular help, meaning that it didn't reduce thrombotic events before the interventional procedure. And in fact, they had a bit more bleeding. And so now we don't use upfront phenylpyridines or P2Y2 receptor antagonists. They can be used particularly in primary angioplasty, but we like to know the coronary anatomy before giving those drugs. Now the next question is which drugs and for how long, and there's a preference to use either ticagrelor or prasugrel because they're somewhat more potent than clopidogrel. And so unless the patient has particular problems, say of greatly advanced age or previous bleeding, or low body weight, we almost always will favor prasugrel or ticagrelor. And then the question is for how long? And I think, by and large, it probably should be at least several months, probably 3 months for so-called dual antiplatelet therapy, aspirin, and the combination with either prasugrel or ticagrelor. And then the next big question is okay, when can we either stop, meaning shorten the course of dual antiplatelet therapy, or de-escalate it, meaning switching from prasugrel or ticagrelor down to clopidogrel. These have largely been aimed at, again, reducing the bleeding risk for patients.
Great. And there's a data on Rivaroxaban also in these populations. What is your take on it?
Yeah, well, so that's a whole other side of the antithrombotic formula, and that's going after the coagulation cascade itself. And so Rivaroxaban has been shown to be of benefit among some patients. I think the most benefit and the greatest use has been in atrial fibrillation, but after an acute coronary syndrome, there's some benefit seen, and also patients who have peripheral arterial disease, some benefit can be seen. I think the greater emphasis has been on antiplatelet therapies for acute coronary syndromes, but certainly the oral anticoagulants such as Rivaroxaban have been shown to be of some benefit. I think that segues now to the next part, and it's patients who do have an indication for an oral anticoagulant, be it apixaban, Rivaroxaban, or Coumadin, largely for atrial fibrillation, but who also have need for antiplatelet therapy because of a drug-eluting stent being placed. And that's a time when we will very specifically remove the aspirin and go to what's called dual antithrombotic therapy, meaning with a single antiplatelet, almost always clopidogrel rather than aspirin or one of the more potent agents, along with apixaban or Rivaroxaban, another agent. And there too, we can shorten the course of that dual antithrombotic therapy if needed if the patient's at particularly high bleeding risk.
So some of these patients will require to have another surgery at some point of time, and then we may have to cut down on the treatment. So how do you go about it?
Yeah, so another great question is if patients need a surgery. It depends on what surgery it is, whether it's vascular or non-vascular, whether it can be delayed, meaning not done urgently. So I think the easiest one is if it can be delayed. Say the patient needs a knee replacement or a hip surgery. Almost always those can wait, and so we like to at least give months of antithrombotic therapy before they proceed with the surgery. However, should a patient need to go more urgently to surgery, it's balancing the risk and the benefit of stopping the therapy. Even if we stop it for days, some patients can be at increased risk depending on what the need for the surgery is. Why is that? Well, because usually there's inflammation, so-called acute phase reactants going on, increased levels of fibrinogen, and so it's very carefully trying to balance the risk and the benefit of bleeding with ischemic complications.
It's great information. So it's all about balancing the risk versus benefit, the thrombotic risk versus the bleeding risk.
It absolutely is. It's that yin and yang, or balance back and forth between preventing thrombotic events, but also trying to minimize bleeding events. And so again, it goes back to the potency of the therapy we use, and then the duration of time which patients are exposed to that therapy. And I think one of the important takeaway messages is that's why we need to aggressively treat risk factors. Because going back to, do we treat with therapy for 3 months, for 6 months? I think it depends on how carefully and how aggressively we can remove the risk factors. Can we get the patient to fully stop smoking? Can we get their LDL cholesterol below 70? Can we get their hemoglobin A1C under great control? And when we can remove those risk factors, then I think we can be more comfortable to reducing the aggressiveness of the antithrombotic therapy.
That's great information. Thank you so much once again for being here.
Well, my pleasure, and fantastic to be with India Live, and look forward to seeing everyone next year.
Thank you.
Insights from the world's best medical minds. You are watching TheRightDoctors.com.